Hi everyone, my name is Zeyu. I'm one of the final year medical students from Barton, London. So today we'll be going through arthritis or painful joints. So we will look at different causes of painful joints, mainly by going through cases. Now, because this is pre-recorded, obviously I won't be able to do any kind of interaction with you. However, I do strongly suggest that as soon as I finish the history, you would pause the video and have a think of what it could be, how you would manage it, and what things you want to rule out first. Okay. As well as this, I will also give you some quick rheumatology facts at the end. Hopefully that will help with your exams. Okay, without further ado, let's go on to the first case. So, case 1, you're at a GP. You see a 40-year-old gentleman who presents with 12-hour history of left-sided knee pain. He is unable to weight bear, and this is what you see on examination. So, what do you guys think will be the top differential? And how would you manage this patient? And is there anything you want to rule out before you go any further? These are the questions I'd like you to think about. So, would you mind please pause the video? Hopefully you've had some time to think about it. And so yes, the first thing we want to rule out with a red hot swollen joint is a septic arthritis. It can happen even in patients who are not feverish. And what would you do first? Definitely you would refer to the hospital and you want to send them for a joint aspirate. And after you've got the aspirate, you want to send it for a microscopy with a G-stain, as well as culture and sensitivity to antibiotics. And as well as that, you want to look under a microscopy to see whether there's polarized crystals to rule out gout or pseudo-gout. So here is a list of what you would see in an aspirate of the synovial fluids. So it's all very self-explanatory, really. So you would expect everything to be clear in a normal sample with low white cell count and low polymorphonucleosides or neutrophils, and obviously it wouldn't grow anything. And in any signs of inflammation or infection, you would expect there to be an increased number of white cells. Therefore, the fluid itself will seem cloudy and yellowish or turbid in color, and it will have a very high white cell count of for pure inflammation, it will be less than 50,000. For infection, you would expect to see more than 50,000. The main differential between purely inflammatory and inflammation is that it's cultural positive in infection or septic joint. And here's a picture of what you expect to see in a patient from patients who are normal, who has an inflammatory joint or septic joint or hemorrhagic joint. Okay. So, whilst you are aspirating the joint of this patient, you notice that the fluid is turbid and it is yellow, and this is what you see. Okay. So, and as well as that, you see that there's 63,000 white cells, and 60% of it is neutrophil. That it's also culture positive with Staph aureus, which is the most likely cause of septic joint. So you would suspect this to be septic arthritis. So how would you further investigate? You would do a blood culture, as well as look for any further inflammatory markers such as ESR, CRP, white cell count. As well as this, you won't want to rule out any sort of end organ damage, just in case you want to give the patient any kind of antibiotics, etc., or any other fluid treatment as well. So here's the list of tests you would do. And imaging-wise, here are the few things that you would consider. MRI is really the best option, but it's definitely not required and it's very expensive, and you don't want to give that to everyone. However, it is the most definitive, thing to look at the joint for any soft tissue damage. As well as that, you can also use X-ray. Ultrasound is needed in order for the aspiration of the deep joint, for example the hip, and X-ray is normally not useful in patients who are septic, However, it may show signs of chondral calcinosis, which are pathognomonic for pseudo-gout. So here you can see left and right is a normal. The right side picture is a normal picture, and the left is a bad X-ray. So you can't really can see that there's a lot of inflammation. The joint itself just doesn't look very healthy. Okay, so in terms of treatment for septic joint, obviously in any kind of OSCE situation or in real life, really, you want to check the local guidelines for the exact antibiotic and the length of treatment. However, in exams, the bog standard they will ask is that you would want to give patient IV flucloxacillin, 2 grams QDS. You can also give gentamicin or clindamycin if the patient is penicillin allergic. Therefore, always don't forget to ask about allergies for patients. And obviously, you want to constantly monitor the patient's OBS, just in case they go into things like septic shock, in which case you will have to fluid resuscitate and carry out the sepsis 6. And obviously, you would consider different antibiotics if it is an atypical organism or if it's elderly with comorbidities such as CKD, and you also want to reduce the MRSA risk with certain drugs. You don't want to use that. And also, you need to reconsider if they've recently had abdo surgery. So, another thing that helps, and as well as therapeutic as well as diagnostically, joint aspiration can help relieve the patient's symptoms. Therefore, it should be done as soon as possible and as often as possible when patients present like this. This all in all, decreased amount of the fluid within the patient's joint, therefore decreased amount of inflammation, and ultimately reduces the pain for patient. Therefore, try to do this ASAP. And when a patient presents in the paper or during an exam with hot swollen joint, they can't weight bear. The option of the first investigation, or the best thing to do, is to joint aspirate. Okay, move on to the next case. Okay, we've got a 26-year-old lady who presented with 1-day history of hot, swollen, painful left knee. So similarly, with the other case, you really want to rule out any sort of septic joint, and especially in this case where you know that her boyfriend has been sleeping around, you want to rule out any sort of STI-related arthritis, of which gonococcal arthritis is the most common cause of septic arthritis in young sexually active patients. So here's what you see in the joint aspirate after you aspirated the patient. And obviously it's turbid, it's yellow, it's high in white cells. Therefore, again, this is septic arthritis. But like I said, have a think what this organism could be. Pause the video if you need to. Okay, so this is what you see in when you take out the aspirate, and you see that there's something known as gram-negative Diplococcus, which is pathognomonic for gonorrhea. Okay, so moving on, I won't cover the treatment. You will talk about that exactly in sexual health. So moving briefly on, I'll go on to a different case. This is a 40-year-old gentleman who, again, you saw at GP, presented with a limp. He has a history of being a build, as well as that he recently had a bout of food poisoning. He said the pain is very severe and he can't weight bear. And you think of the diagnosis in your head and you've ordered some test. What do you think that could be? Again, have a think. Okay, so the test we ordered is HLA B27, which came back as positive. So again, think about what will be your top diagnosis and how would you manage this patient. So yes, the top diagnosis we want to think about in this case is reactive arthritis. Okay, it can be caused normally by stomach bugs. Campylobacter is the most common, as well as Shigella and Salmonella. This usually occurs 3 to 4 weeks after the infection, as well as this STIs, chlamydia, etc. can also lead to reactive arthritis. Okay, there's a triad of symptoms that you would expect to see, or typically you will see in an exam situation, is that the patient have joint pain. They also have conjunctivitis, as well as some sort of urethritis. People say people with reactive arthritis is that they can't see, they can't pee, and they can't climb a tree. So that's quite a good way to actually remember of the 3 things that's kind of suggestive reactive arthritis, alongside the recent stomach infection. So obviously, again, you want to rule out any serious conditions such as septic joint. Otherwise, if you've ruled that out and you know that reactive arthritis is the definitive diagnosis, then the patient would normally get better by itself, and within around 6 months' time to fully recover. So therefore, you would treat this mostly conservatively with analgesia, okay, such as NSAIDs. So here is a few conditions that is also related with HLA-B27. The first one is psoriasis, and the second one is ankylosing spondylitis, and then it's IBD and reactive arthritis. Therefore, you can put this in your 4 with mnemonic of pair. And obviously there are more. However, in OSCEs you're only expected to list 3. 4 is definitely good enough. So moving on, this case, you've got a 71-year-old lady with known CKD. He has 1-day history of painful right big toe, of which is 9 out of 10 severity, came on within hours, and she has a family history of arthritis. We don't know much other history at this stage, but considering the joint affected as well as CKD, what do you guys think will be the main diagnosis? Again, pause the video, have a think before you look at the answer. This way you help to learn. Okay, so as well as that, what do you guys think will be the risk factors you want to ask about? Have a think. Okay, so risk factors including diet, so ask about whether the patients love the red meat, seafood, as well as other food that's high in purine. As well as that, alcohol is another risk factor. Drugs includes aspirin, cyclosporin, cytotoxics, diuretics, especially thiazide diuretics and lube diuretics, or increase the chance of gout. You need to learn this for the PSA, which they love ask about thiazides and the risk of gout from diuretics. As well as that, ethambutol, pyrazinamide, tacrolimus, and many others can also cause drugs. So a detailed drug history is very crucial for gout. So disease-wise, things like obesity, hypertension, diabetic mellitus, renal impairment can all contribute to gout. Okay, so here's a few pictures of gout. Here you've got your classic tophi, you've got your big toe being affected, and the one on here, it's definitely looking very heart swollen, and maybe this probably infected as well. Okay, so again, obviously when you see a joint like that, you, like I said, if it looks infected, you need to rule out septic arthritis. And then you can think about gout, pseudo-gout, rheumatoid arthritis, as well as osteoarthritis, given that she has a history of arthritis. And obviously you want to rule out reactive arthritis as well. However, given her demographics and history, that's probably the bottom of the list as shown here. So in investigations, generally gout is diagnosed clinically with a history, but a synovial fluid is definitely definitive in terms of diagnosis. So especially the polarized microscopy. I'll show you a picture of that later on. And as well as that, you want to check the uric acid, especially 4 to 6 weeks after the attack. However, this does not confirm or exclude gout. So they could have normal levels, but they they still get gout. Okay, as well as that, you want to, like I mentioned before, you want to do a joint X-ray to rule out any signs of chondrocalcinosis, which is suggestive of pseudo-gout. So you think about gout if it's acute onset within a day, and it only affects one joint, especially the big toe, as well as any history of previous attacks, which all could be suggestive of gout, as well as increased uric acid levels. And apart from that, you can also see that there's no organism in the synovial fluid aspiration. So here is what a typical result would look like for someone that's having a gout. So their MC and S will be all negative, and as well as that, they will be showing polarized microscopy, as shown here, which shows the typical yellow needle-shaped, negatively birefringent crystals, which is a buzzword they like to use in exams as well as data interp. So what is the management? Okay, so first line in acute setting is NSAIDs. So that includes your diclofenac, naproxen. You want to rule out that if they are taking NSAIDs, that you want to make sure that, because it can lead to peptic ulcer disease, as well as worsened kidney disease, and IBD, TIA, and stroke, you want to avoid NSAIDs in those cases. And to protect the gut lining, you would add a PPI. So you would consider using colchicine if they have these contraindications as an alternative. And the main side effect that you need to be aware is diarrhea. You can also consider intra-articular steroid injections. And a question I'll come back to later on is that, do you think whether you would continue gout if you're having an acute attack? I'll come back to that later on. And what treatment should Miss Miriam be on for her gout in order to prevent it? As well as this, remember that she has CKD, and do take that into consideration when managing. And then, so soon after, she came back to you again, having 3 more attacks of gout in the last 6 months, for which they have settled by now. She is getting tired of having them, and her GP says that another tablet she can take to stop her attacks. And what do you guys think this could be? Have a think? Okay. So, yes, allopurinol. So allopurinol is a xanthase oxidase inhibitor, and obviously another alternative actor in the similar pathway is febuxostat, if you can't have allopurinol. And generally you want to start the drug around 2 weeks, after the patient had 2 or more gout attacks in a year. Okay, and like I said, going back to this now, you should never initiate or start allopurinol during the initial acute attack. However, if they are already on allopurinol, then they should keep on taking it during the attacks if they're already on it. However, if they have never had it before, do not start them on allopurinol. Okay, this will worsen the gout attack, and they will increase the pain. So you want to, in order to treat acute treatment, you want to co-prescribe the treatment with allopurinol for the initial weeks and months, NSAID for 6 weeks, and colchicine for 6 month-ish, or 6 month-ish. And this is so that if they have it, they can stop the attack. If they feel gout is coming, if they have the acute treatment early enough, it can stop the attack from occurring altogether. Okay, so now moving on to another case now. Okay, so you've got a 79-year-old gentleman who presented with a swollen and painful left knee for the past week. You suspect this is gout. So what kind of investigation would you do first, or in any joint situation with a red hot swollen joint? Of course, you would aspirate. And here's what you see under microscopy from the synovial fluid. And how would you describe this? Have a moment to think about it, or pause the video up here. So you would see bluish, positively birefringent, rhomboid-shaped crystals. Again, this is pathognomonic for which condition? Have a think. Yes, I'm sure you got it. It's pseudogout. Okay, so here on X-ray, you would see something called chondrocalcinosis, like I mentioned before, which is pathognomonic for pseudogout. So what is the treatment for pseudogout? Obviously, you want to aspirate the joint, plus minus steroid injection. That will be decided by a much more senior than a junior doctor, as well as that you would consider giving NSAIDs or colchicine. And for pseudogout, colchicine can actually be prescribed long-term as a preventative measure. Okay. So here you can see that the differential diagnosis between an inflammatory joint versus a mechanical joint. So an inflammatory joint is normally worse in the morning, where you get morning stiffness, whereas a mechanical joint is worse after a day of walking or day of moving about, where it's being increased stress. As well as this thing for inflammatory, exercise makes the joint better, and mechanical, obviously, the more you move it, the worse it gets. And NSAIDs helps a lot in inflammatory, but has limited effects in mechanical joint. And obviously, you would also get morning stiffness, which lasts for around 1 hour or more than 1 hour in inflammatory joint conditions, as well as for mechanical, it would last around probably less than 30 minutes. And inflammatory is normally seen as red and hot, and mechanical is normally you wouldn't be able to see anything. And inflammatory-wise, it can involve multiple joint and other conditions such as uveitis or Achilles tendonitis, whereas mechanical, there are usually no other associations. Here's another case. So you've got a 2-year history, 47-year-old lady with 2-year history of multiple joint pains, swelling in her hands and ankles. Pain is worse in the morning, eases off by the evening. So like, already you know from the previous slides that it's going to be something inflammatory, especially given that she's a lady, slightly not too old, and she says stretching again loses the joint, helps with the stiffness. She often feels that she can't move, and she feels like a 90-year-old, has dry eyes, multiple tender swollen joints in her hands, and a positive MCP squeeze test. So dry eyes, another word for dry eyes is keratoconjunctivitis sicca, which you get dry eyes as well as a decrease in production of tear. And DIPs are normally unaffected, therefore the MCPs are more likely to affected. So what would be your main diagnosis in this case? And which joints do you expect to be affected? Again, have a moment to think about it. Okay, so investigations. So for any joint conditions, again, you want to rule out anything inflammatory or septic associated. Therefore, you want to do your FPCs, CRP, ESR, USNEs, LFTs, which are all very important in rheumatology exams. As well as that, you can also consider some antibodies, such as rheumatoid factor, anti-CCP, ANA. This is given that you have a diagnosis in your mind, and the diagnosis we want to think about is rheumatoid arthritis, really. And in rheumatoid arthritis, rheumatoid factor is positive in 60 to 70% of RA patients, but it may also be positive in healthy. So it's very sensitive, but not very specific. Okay, so CCP is more specific than rheumatoid factor, which means that if it's positive, it's not really positive in a healthy patient, and if it's positive, then it's highly suggestive of rheumatoid factor, rheumatoid condition. And again, ANA is very non-specific as well. You would consider imaging such as X-ray of the affected joint, as well as ultrasound and MRI. Here's a picture of typically what you would see in rheumatoid hand. You can see that you've got some sort of damage in this joint here. However, the distal joint, DIP, is not affected. You can see that there's obvious increasing kind of wear and tear, as well as kind of collapsing of the joint, mainly due to rheumatoid. And here's your typical ulnar deviation of in rheumatoid arthritis. The initial treatment, normally you would start the patient on DMARDs, disease-modifying anti-rheumatic drug, with a short course of steroids. And obviously, we use steroids for a lot of conditions, especially inflammatory conditions, but it has a lot of side effects. You need to learn those, and they love to ask about this in both rheumatology as well as GI and endocrinology. It's very commonly asked. I won't go into too much detail for that just here. So in terms of DMARDs, you've got, as well as that, you've got the biologics, steroids, especially taken orally for stubborn rheumatoid arthritis, as well as injections for large joints. So the main DMARDs we would consider is methotrexate, for which you need regular blood tests, especially full blood count and LFTs, as it can cause a granulocytosis, as well as that it can lead to deranged LFTs. Therefore, you need regular blood monitoring for those. And sulfasalazine, again, similar. And hydroxychloroquine, you need, it's known to affect the eyes in terms of the side effects. And the flunomide, you need to monitor the blood pressure. Okay, so first line would be DMARDs, usually methotrexate, and then you would consider adding another DMARDs, and then you would move on to biologics. So here are a list of biologics, including etanercept, rituximab, adalimumab, toxilizumab, abatacept. Can't really say them properly, but here are the list. There are new ones being licensed all the time. Obviously, you need to be aware of the side effects. The main one is that it can reactivate TB, as they're all immunosuppressive. Therefore, you need to have a chest X-ray before you start on any of these drugs to rule out any signs of latent or active TB. So, how do you monitor rheumatoid? So the thing you would want to do is you want to do a score called Disease Activity Score, or DAS-28. It looks into how many tender or swollen joints you have, as well as inflammatory markers, and then you get a subjective score for each of the patients. And this helps to decide exactly which treatment to do, as well as the dose of the treatment as well. So if a high score, you would increase the treatment or increase the dose. If you have a low score, then you would consider observation or decrease the amount of dose or stopping the drug. So you started prescribing her methotrexate and 2 weeks course of steroids. Again, I think we mentioned this already. What precaution do we need to know apart from the blood test? Okay. So one thing you also need to do is that you also need to tell her that she can't have any children. So she needs to be on some sort of contraception, and they need to report any signs of illness to doctor immediately, and to make sure that she takes folic acid. Okay, she shouldn't get pregnant, and especially when she's on methotrexate, and she needs to be off methotrexate for 6 or more months before she tries. It's very important. If you see this question or advice question in PSA, the answer will be to make sure that she's having contraception. That's the most important advice you will give to a patient who starts on methotrexate. As well as this, now we want to talk a little bit about psoriatic arthritis. We briefly mentioned it in the seronegative spondyloarthritis section. Typically, you would see a typical appearance on X-ray of this penciling cup appearance, and mostly affects the distal interphalangeal joints. And they may have a very similar picture to a patient with rheumatoid arthritis, but they would have a history of psoriasis. As well as that, they would have HLA-B27 positive in their blood. Well, not all of them, but it's suggestive that it's psoriatic if they are HLA-B27 positive. Yeah, so penicillin cup, typical. We've got a 27-year-old male who presented with tiredness. Okay, he has a history of back pain, stiffness for the past few years, but he just put down to various injuries when he's had younger. And he also had pain and stiffness in the morning. And again, it gets better with activity and improves with ibuprofen. The pain also wakes him up at night. The neck movement is limited and Schober's test is positive. What's your top diagnosis? Okay, again, take a moment to think. Okay, having just spoken about seronegative stuff, of course the top differential in this case is ankylosing spondylitis. So what would your diagnosis and management be? So here's typically, what you would see in ankylosing patient. So picture A is normal, and B to D shows worsening signs of sacroiliitis on X-ray. Okay. So you can see the loss of space and fusion of etc. You won't need to know how to read this, but here is just what it looks like. Okay. So again, right hand side is normal, and here you can see that there's definitely some asymmetry as well as some sort of fusion of the joint and sacroiliitis. Okay, that's what it looks like. And you've got sacroiliitis on MRI on the right, and then here's the normal image of what it should look like. And here you've got a spine. A spine should not be this straight. Okay, and this is otherwise known as bamboo spine, which is pathognomonic for ankylosing spondylitis. So what other features you might get? A lot of it starts with A. So you've got your Achilles tendinitis, and then you've got your anterior uveitis, and then doesn't start with A, but dactylitis. So what investigation you would consider doing? You would consider doing obviously the HLA-B27, but it's not diagnostic. Therefore, a lot of it is going to be history as well as looking for these kind of comorbidities and the clinical assessment. So, like I said, HLA-B27 is associated but not diagnostic. Therefore, you want to do FPC, ESR, CRP. So how would you treat it? Have a think about it. Yes, NSAIDs, PPI. Hopefully you get the gist now. Most rheumatology patients are on NSAIDs and PPIs. As well as that, you would then consider TNF if uncontrolled, etanercept, adalimumab, etc., etc. So, as well as that, you can consider steroid injections in the sacroiliac joint, and then as well as if you've got enthesitis into the Achilles tendon. Okay, so moving on from there briefly. Now, going back, you've got a 78-year-old male now with multiple joint pains in his hand. A few years, it's been happening for a few years now, slowly getting worse. He's been having difficulties in his ADLs, like dressing and feeding. The pain is worse when he uses the hand, and he regularly breaks from his hobbies like piano and gardening because of the pain. Recently, his knee has also started hurting. He's noticed some hard bumps on his knuckles. Okay. So you can see these bumps. So what do you think they are? Okay, so yes, they are Heberdin's nose and Bouchard's. So diagnosis is mainly clinical, but obviously you want to investigate to rule out any sinister causes. And obviously X-ray is very helpful, and you need to, like I mentioned, again, you need to rule out anything septic, especially if it's only one joint, as well as any inflammatory causes of arthritis. In comparison to rheumatoid arthritis, which is asymmetrical, whereas RA is symmetrical and it may have systemic features. So here, showing signs of OA, you can see that on the figure 1, you got normoid joint space, and in figure 2, you can see that there are bony spurs, as well as narrowed joint space from the loss of cartilage, which is pathognomonic for osteoarthritis. As well as that, you can also, here's another X-ray image. Again, you can see bony spurs and narrowed joint space. And this is what it would look like on the hand X-ray in terms of Bouchard's and Hebden's nodes. Obviously, left is normal, right is osteoarthritis. It normally affects the first carpal metacarpal joint, as well as that it affects the DIPs and PIPs, unlike RA, where it only doesn't affect the DIPs. Here's a picture illustrating it, and here's illustrating which one's Hebden's node and which one's Bouchard's nodes. I remember it by alphabetical, really. So Bouchard's comes before H, so B is closer and the H is further away. Okay. And here's what it actually looks like on a patient. Hebden's nodes. So how would you treat it? So unfortunately, there's no cure for this. Mostly it's physio. Other than that, it's painkillers. You can use some splints and other devices, as well as steroid injections. You can do physiotherapy, painkillers, splints, and other devices, as well as steroid injections. However, these are purely to manage the symptoms. It does not in any way cure the disease. You will have to re-administer when the symptoms reappear again. And ultimately, the only way of curing it is by having a joint replacement through surgery. So in terms of pain management, obviously you want to start your pain ladder on simple analgesic like paracetamol, as well as topical NSAIDs, especially for hands and knees. And then you want to consider pure NSAIDs, for which you need to give PPI. And as well as that, you can then go on to opioids if it's not controlled, and then topical capsaicin, which is a topical strong NSAID. As well as that, you can also use intra-articular steroid injections. And here's just a picture of what a joint would look like before and after. So you basically become a cyborg, and but they don't, from what I've remembered, they don't really give off any signals through security or anything like that. But nevertheless, it's pretty cool. So here's the rheumatology antibody cheat sheet that I promised at the start. It's a very small list. There's a few others that you need to know, but these are the ones that definitely will come up, and you need to know these. Okay, I won't go through them individually. But thank you for listening. Please fill out the feedback form provided in the description, and you will receive the slides for the lecture after you've completed it. And please do remember to subscribe to this channel to keep up to date with any of the upcoming lectures. Thank you.